Good afternoon. I'm Howard Husock, Senior Fellow in Domestic Policy Studies here at the American Enterprise Institute. We're in the midst of an epidemic of drug abuse in the United States. More than 100,000 of our fellow citizens died last year from overdoses, many linked to the advent of the powerful synthetic opioid fentanyl. Some call these deaths of despair, but that's a term that implies that little can be done to reverse this trend. Overdose deaths do appear to be slightly decreasing, but that doesn't mean that addiction and hard drug use itself has ebbed. Even as overdoses and addiction continue, however, an unprecedented new source of treatment and prevention funds has emerged. The so-called National Opioid Settlement means that firms that manufactured or distributed drugs that have been abused must devote more than $21 billion and counting to dealing with their aftermath. The arrangement is often compared to the National Tobacco Settlement, through which cigarette companies had to compensate states for smoking-related medical expenses. But there's a key difference with the National Opioid Settlement, and it's a difference at the heart of the discussion that we'll have this afternoon with a panel deeply conversant with the subject. Most of the opioid settlement funding will go directly to local and county governments whose citizens have suffered. The compelling logic of doing so aside, it's also true that many local governments have little or no experience with how to mitigate or reverse this wave of drug abuse. This afternoon, we'll seek the opinions and insights of physicians, public health and treatment experts, and a journalist closely following the disbursement of these billions now being distributed. Our goal is to provide guidance as to good practice, what might actually be most effective for local governments which find themselves on the front lines of prevention and treatment. We'll begin with keynote speaker Dr. Thomas McClellan, the founder of the Treatment Institute, dedicated to what it terms science-driven reform of treatment and policy in substance use. A longtime professor of psychology at the University of Pennsylvania, he has more than 35 years of experience and counting in addiction treatment research. From 2009 to 2010, he was the presidentially appointed science advisor and deputy director of the White House Office of National Drug Control Policy. Following Dr. McClellan's remarks, I'll moderate our distinguished panel of expert respondents. Irma Esperanza-Diggs is a senior executive at the National League of Cities. She's previously served as chief of staff in the Office of Legislation and Congressional Affairs at the Federal Department of Education and chief of staff for the District of Columbia City Council, which I'm sure will be receiving opioid settlement funds. Teresa Miller, to my right over here, is National Director of Health Initiatives at the Legal Aid Center. She has spent most of her career in state government, including as Secretary of the Department of Human Services in Pennsylvania, leadership roles as an insurance regulator in Pennsylvania and Oregon, and she served as well as the president and CEO of the Kansas Health Foundation. Aniri Patani of KFF Health News is among the journalists most closely following how local governments are deciding how to make use of opioid settlement funds. She's a KFF senior correspondent. Her work on the flawed oversight of drug treatment facilities won a 2021 award from the Institute for Nonprofit News. She was the 2019 recipient of the Rosalind Carter Award for Mental Health Journalism. And Dr. Sally Satel is a senior fellow here at the American Enterprise Institute. She's a practicing psychiatrist and a lecturer at the Yale University School of Medicine. She serves as a staff psychiatrist at Partners in Drug Use Rehabilitation and Counseling here in Washington, where she assists patients in recovery from addiction. Sally's on the front lines of this issue. I turn now to Dr. Tom McClellan.
Well, thanks, Howard. I appreciate the opportunity. I want to just try to set the stage a little bit for the conversation that will follow. I'll first say that I have a few conflicts of interest. I've served on the boards of these companies, And I will be talking about one thing that Shatterproof is doing, but nothing of any of the others. So let's start by giving a picture of what substance use looks like in the United States. As you can see, this is a depiction of an entire population of adults, 12 and over, and it's a pyramid. So as you go up the pyramid, you go from no use at all to very severe, very frequent, high-intensity use. Well, the first thing you notice is the base of the pyramid, where most of the population is, doesn't use any substance at all. By the way, this includes all substances except for cigarettes. So marijuana, cocaine, opiate, barbiturates, benzodiazepines, all of them. All right. Now, as you go up, you see that wavy line with dashes in it. It's wavy because depending on the substance, more or less of the population is using it. That's where use turns into misuse or harmful use. And that is use at a frequency or under circumstances that produce harm to you or to those around you. And 40 million people are using in a manner that is bringing harm to themselves or others. Now, as you continue up the pyramid, you get to that bright line there, and that's where misuse turns into addiction. And as you can see, about 21 million people meet criteria for a serious substance use disorder commonly known as addiction. The top of the pyramid is that proportion of people that are getting any kind of care at all. Now, notice that I've talked about use, misuse, and addiction. And the reason I bring that out is that they are controlled by different factors. Use is controlled by the same factors that cover any other market. Hershey bars, Ford trucks, you make them more available, easier to get, cheaper to get, you have more people using, okay? Misuse is controlled by consequences. So drunk driving tickets reduce drunk driving. Sanctioning college kids that can't make it to class on, Friday night because of, drinking too much, that reduces misuse. Addiction is entirely different. It is governed by biological factors, and we'll talk about that. And above that line there is what is called substance use disorders. It's the generic term for the continuum of severity, from mild to very severe. Okay, so let's talk about how we think about addiction. And first, let's talk about if we had a person who's in active addiction walk through the door, what kinds of behaviors might they be exhibiting? And these are some of them. Self-harm, antisocial behavior, inability to delay gratification. They're erratic and hard to predict what they're going to do. They swear they're never going to use alcohol or marijuana again, and they do the next day. Rather characteristic is the denial of the existence of a problem. Denial, by the way, is not lying. It's they really cannot see what everybody else around them sees so clearly, that they have a problem. And if you had to sum that all up, and if you were confronted, as people throughout the ages, many countries have been, it's easy to think that this is a character disorder, that there's just something wrong with these people. Maybe it's from birth, maybe they didn't have good parenting, maybe they didn't have enough religious training. Maybe that's what it is. So the reason that's important is those kinds of thoughts shaped what ultimately became the American addiction treatment system. Now, under the view, if you have the view that addiction is due to the learned or innate character problems, the smart thing to do would be to get these people, confront them, get them to admit that they have addiction, and get them to understand that they need to take control over it through confrontational methods. And much of our addiction treatment system from the very early stages, and I'll talk about that in a minute, is designed to teach people that have been thought to have these innate character problems good things: discipline, gratitude, honesty, humility. You can't argue that these are bad things. And the hallmark of it is for them to learn to control their problem by not using at all. Part of what they have to come to admit is that they are powerless over the use of the substance. So those thoughts gave rise to the initiation of the American addiction treatment system. It started out about 12,000 treatment programs, and it was initially in response to the influx of Vietnam-era veterans who were coming back from Vietnam with opioid problems. The Nixon administration simply was politically impossible to incarcerate people who had given their time and efforts to defend the country, came back with an illness. But medicine didn't want anything to do with them. There wasn't anything available, so they developed these and funded them with state grants, block grants, about 12,000 programs. It's a program because everybody in the program gets the same thing, okay? And it created a brand new profession called addiction counselors. And it was thought that because this is such a peculiar kind of a problem, there's only one kind of person who really can get through to a person who's in active addiction, and that's somebody who has themselves gone through it and learned to deal with it. Very important. From the very beginning, the addiction treatment system was purposely segregated from the rest of healthcare. Segregated in every way: culturally, geographically, information exchange, everything. It was designed to protect this fledgling treatment system from forces that might steal their money and also that nobody else wanted to do anything with them. So I've just described these problematic behaviors that are associated with so many addictions in a certain way, as a character disorder. Is that how we concurrently see it? No. After 50 years of research, we have a different view. And we now believe that addiction is brought about through, purposeful behavior initially of using drugs. But the act of using drugs and repeated high doses produce systematic changes in gene expression. Not a single gene like is responsible for your eye color, but a constellation of genes that determines how behaviors are expressed. It produces changes in the stress response system and in brain circuits, specific brain circuits that control motivation, inhibition, reward sensitivity. So to take a step back and think about those characteristic behaviors that I put up in one of the early slides. One way to describe them is that they have a character problem. Another way to describe it is they have systematically altered the way their brain functions, and perhaps for a very long period of time, leading to diminished control over their ability to use. Now, what evidence is there for any of that? Is that just speculation? No. My colleague, Dr. Nora Volkoff, who runs the National Institute on Drug Abuse, has been doing work for decades now on brain imaging. Just as in the study of heart disease, you can characterize the way a heart functions with an MRI, you can characterize how a brain functions. So this first slide at the top row there are brain slices. If you sliced my head this way and took a picture of how the neurons were functioning, specifically how glucose was being metabolized, you see every place where there's yellow or red, a lot of glucose function, a lot of neurological function. Well, what does a brain look like that has been addicted to cocaine and is now 10 days sober? You don't have to be a brain scientist to see there ain't much yellow or red in those pictures. That means that the neural function is not functioning in a normal way. Very importantly, if you ask people who've just completed detox, 3 to 5 days in a detoxification facility, how do you feel? They'll say, wow, I feel a lot better. Doc, I've decided I'm never going to use again. I've learned my lesson. And they mean it. But as you can see from this picture, they're not playing with a full deck. They don't have full control, and they're not able. It's not that they've lost total control, but their control of their behaviors is diminished. Does it ever get better? How about if we see brains 100 days sober? And as you can see, there's more return of function there. It's not, quote, normal. We don't know if it ever gets to be normal. I think this is the longest period it's ever been brain imaged. Also, we don't know if these individuals started that way. But we do know two things. That when you see changes of this nature, you're talking about a medical condition. Two, you know that if you see changes of this nature and they don't correct in a fairly short period of time, you're dealing with a longer-term problem. And that leads to the next part of this talk. If you think that you've got a character disorder, you treat a person a certain way. If you think you have a chronic illness, something where you've got long-term functional problems, diabetes, hypertension, asthma, chronic pain, rheumatoid arthritis, lots of chronic illness, you treat it differently. Let's take a look at that. Here's a traditional model of how you get treated in a rehab facility, the, quote, 30-day treatment programs, or it could be a 60-day outpatient program or a 90-day outpatient. You start with a substance use disordered patient who enters Shady Acres treatment program. In that box, there is a fixed program of care. Everybody gets the same thing. The idea is to get them to complete. And when they complete, they should have learned that they have a problem, accepted it. They should realize new ways of dealing with the kinds of craving issues that they're going to confront when they get discharged. And as you can see, because it's a nice fixed box there, right about at the lower part of that, there's a discharge ceremony. Everybody's hugging and crying and wishing Johnny the very best. And then 6 months or 12 months later, Tom McClellan comes along to see if the treatment program worked. You do that by seeing if the patients are still abstinent. If they are, treatment worked, hooray. If they aren't, well, either the patient wasn't ready or treatment was bad. All right, that's very traditional. But it's different than if you thought this condition was a continuing care kind of a problem, like diabetes or asthma or hypertension, where you don't have a cure, but you can manage. It's very different. First of all, it starts with primary care, where, because the physician and the nurses and the primary care team have all been trained in the course of their education to diagnose and handle chronic illnesses, and because they have an array of medications and behavioral therapies and support services, they can often handle a chronic illness right in the least intrusive type of care available, primary care setting. Now, sometimes that doesn't work. The symptoms get out of control. And what do? Well, you transfer, and it's usually, quite literally with the touch of a button on your electronic health record, you transfer to specialty care, where they have a different array of medications, people who are highly specialized, medical devices. And the goal of specialty care is not to cure. There isn't a cure for diabetes or arthritis or anything. It's to reduce the symptoms, increase the function, and then send them back to primary care where they can continue now at a level of severity that is manageable in the outpatient setting. A couple of points here. One, you don't want to let the patient out of care. You know that the effects of any of this care are only going to last as long as the patient is involved actively in the course of care. To my knowledge, they do not have 30-day diabetes programs, for example. 2, evaluation is a clinical activity because they don't have diabetes or hypertension programs. They have tailored types of care. And the evaluation, like a blood pressure cuff or whether you have a test for whether your glucose is, hemoglobin A1C is below 6%, that has 2 functions. 1, to evaluate whether whatever has occurred before that test has worked, and 2, it's designed to guide what happens in the next days and weeks ahead. That's very important. The idea in chronic care is to tailor care to the specific constellation of problems that a patient has. Okay, so I think we could skip this slide here. I basically covered it. So at this point, you can probably tell why the original system set up in the early 1970s failed. It never fit what later the developing science taught us about what some of the underlying causes of addictions are. 2, it was segregated. I hope this is the last vestige of segregation that is in our system. But it was purposely segregated from the rest of mainstream healthcare. To this day, less than 30% of American medical and nursing schools have a single course in addiction. It was never insured until about 2010 with the Affordable Care Act. So it didn't have insurance dollars to fund it. Even the information collected in the course of addiction treatment was not allowed to be shared with the rest of medicine, which created many dangers. There were no systems, as there are in the rest of medicine. Whether you like pharma or you don't like pharma, there's a lot of money to be made in a pharmaceutical company if they can develop a better medication or medical device for a condition. There aren't any of those incentives in the addiction treatment field, and we don't have, unlike illnesses like where they have the American Cancer Society or the American Diabetes Association, there's no advocacy advocating for better, more informed care. So, gee, ain't it awful? And what are we going to do? Does that mean there's nothing that can be done? Not at all. And these are there are many issues that state policymakers are facing right now. Like, we're going to get new dollars. What do? I mean, the easiest thing to do would just be buy more of what we have. We've already got existing contracts. We'll just re-up them. Is that a good idea? Or could we do better? Could we use the power of state block grants, new dollars, and contracting to improve things? So let's examine the first. It's not a bad idea, especially if we know we don't have enough treatment available for everybody. It wouldn't be a bad idea to simply buy more of the same, as long as what we have is pretty good and we have good reason to think that, more money will incentivize others to come in. But working with the nonprofit Shatterproof, they've been doing something that's very kin to a consumer's report. And I'm going to show you the evidence of this in this chart. Along the top this is actual data, by the way, 12 addiction treatment programs for adolescents, outpatient adolescent treatment programs in the city of Philadelphia. And the programs are along the top. Just like if you were reading Consumer's Report and you were interested in buying a lawnmower, it would be the lawnmowers along the top, and along the side are the quality dimensions that are important for determining the outcome of addiction treatment. Now, you get a green sticker if you've got a lot of evidence-based practices in a certain dimension. You get a yellow if you have a few, and red if you have none. So here's program 1, and if you look at it, not too bad. Lots of evidence-based practices. When I say evidence-based, I mean medications, behavioral therapies, recovery support services where research has shown them to be important and effective in affecting better outcomes. And as you can see, Program A has quite a number. They don't do program evaluation. That's why there's a red, but they're not paid to do it, and they don't do it, but not too bad. Here's the rest of the programs. I repeat, these are actual data. So what you're seeing there is very little evidence-based practice going on in contemporary outpatient addiction care. You can characterize it primarily as group counseling. And when that doesn't work, well, you get group counseling. And if that doesn't work, you get group counseling, because that's what they are paid. So the 2 points here. One, you're paying, as a state agency responsible for licensing and regulating care, you're buying this stuff. And two, you can know what you're buying. So were I to be in charge of these new dollars, and if they were going for new care, I would insist that the programs admit to external evaluation of and publication of what they're providing. So that's one way a state can use their money in a new way. And here's very quickly the last way. This is one of my favorite studies of all time. It was done in Delaware. In around 2001, Delaware had an influx of money, much as the kind of money that you're seeing now. It came out of nowhere, but it was a 9% increase. And then state director Jack Kemp said, you know what? I'm not going to give these treatment programs the 9% additional money, at least not for the same thing. I want them. Every one of our outpatient programs has got a contract for, let's say, 100 treatment slots, and the best they're doing is like 40% occupancy. So that's telling me that the program's not very attractive. It's not getting people in, and that's not providing value to the citizens of Delaware. So what he said was, look, to the 16 addiction treatment programs then in operation, he said, I'll tell you what, I got bad news and good news. Bad news is, starting 2001, you're going to get only 90% of what you had last year. Now, before you start screaming, you can make 109% of what you had last year, and I'll pay you every month. But I'm not going to pay you for doing the same old thing. I want to see more patients in treatment, and I want them to stay longer. If you can do that, that's valuable to the state of Delaware. If you can't, I don't want to pay for it. So here's the results of that. The contract this is the year before the contract went in, and this is the census for programs in Delaware. And at that point, it was like 40% of what they were paying for. First year of the contract is in yellow because it wasn't fully implemented, but you can see census went up, and here's the first, second, third, fourth, fifth years after the contract. It tripled the number of patients in the care of program. I have a similar graph I won't show you of length of stay for 30, 60, and 90 days. Doubled length of stay. Point. States are market makers in the addiction treatment field. They have tremendous power. They can contract to get value for their citizens. So with that, I'll close and turn it over to the panel. I hope it's set the stage for some discussion of things that could happen in the future.
Thank you so much, Tom. After our panel discussion, we will have a chance to have audience questions, including from our vast online audience, and those can be directed to, do I have this right, hadar.zeevi@aei.org, HARDAR first name dot last name zeevi.aei@aei.org. So think about your questions while we're continuing this. So let me just follow up quickly with you, Tom, before I turn to the others on the panel. Are there new mistakes that are being made? I have a couple of things in mind. We're seeing recreational marijuana being legalized across the country. We're seeing harm reduction centers where addicted persons are allowed to inject drugs under medical supervision. Are those meeting people where they are and understanding that this is just a new approach, or are these new mistakes that we might be making?
I don't know if this is, I'll give you my opinions on this. I don't have factual data studies to support it, but A, it's my opinion that it's a bad idea to legalize marijuana. If you go back to that pyramid, what you're going to do by legalizing is you're going to broaden the base of users. And for every substance that you can think of, when you increase the number of users, 30% roughly are going to develop harmful use. They're going to get into a car accident or have a interpersonal violence or something that's a problem associated with the use of that harmful use of the substance, and 10% are going to have an addiction. So my personal view is decriminalization is the way to go with marijuana. It's crazy to put somebody into jail and ruin their livelihood for the rest of their lives based on marijuana possession, but to sanction it is, in my opinion, is wrong. It's hard to argue against something as nice sounding as harm reduction. Who is for harm production? I don't think anybody. But for me, I draw the line when there is I'm for any harm reduction procedure that also reduces substance use, because I think it's a fact that most substance use, and certainly harmful use, is not good. So I like lots of the things that they talk about, but safe injection sites have not demonstrated that they would get more people into treatment. They're very expensive. They're dangerous. I don't think they're warranted.
So we're seeing new potential. Your basic theme, let's integrate this into the health system, but we're also seeing maybe new false paths in your opinion. Okay, I want to turn to somebody who is covering this issue on the front lines, Anuri Patani from KFF Health News, former Kaiser Health News. What are you seeing at the state and local county level in terms of how these opioid settlement monies are being dispersed? And I understand you actually have some news about that you can share with us.
Yes, today is the perfect timing for this panel. So my colleagues at KFF Health News, along with folks at the Johns Hopkins Bloomberg School of Public Health and Shatterproof, actually have been working.
What is that, for those who don't know what it is, the Shatterproof?
It's a national nonprofit that works on addiction policy issues and advocacy. But so our three organizations have been collaborating for a year, trying to answer exactly the question that Howard just posed: how has this money been spent? And we built a database going through public records at state, county, city levels across the country from what we could find, and built a database of more than 7,000 ways that state and local governments spent this money or used it other how in the first few years that they were receiving it, so 2022 and 2023. And just big picture, I'll show you, there's a lot we can get into, but we found that during those 2 years, 2022, 2023, state and local governments received about $6 billion in opioid settlement funds. Of that, roughly a third they spent or committed to spending on a variety of initiatives. Another third they basically set aside and said, hey, we're going to use this in future years. We haven't spent it yet. And the final third, we actually could not track because there are no public reports about that money. And so it's not clear if they spent it, didn't spend it, or how it's being used.
Right, so let's drill down on that. Dr. McCollum was talking about treatment. Is there any way to know what kind of treatment programs this money is going for? Because he has some pretty strong and seemingly informed views about what works and what doesn't.
Yeah, so in our data collection, we found more than $416 million of the opioid settlements went to treatment broadly. And
that's a pretty small number out of the whole big number, isn't it?
It's the largest chunk, I would say, that of the expenditures we found, it is the largest chunk. So funding treatment was clearly a priority, but then to your question, that can mean a lot of things. And so when we've made the database available to the public, everyone can see it on our website, all 7,000 plus lines of it if you want to go through it. But you can see in that some of the treatments are things that experts generally point to, medications for opioid use disorder, residential facilities with counseling. Some are the, abstinence-based or group therapy only, kind of the varied approaches that Dr. McClellan pointed out are all being funded with this money. And so just because it's going to treatment does not necessarily mean it's going to evidence-based treatment.
Or effective treatment. He was talking in Delaware about what we call performance-based contracts, and that may or may not be a thing.
That's correct. I think the opioid settlement money being spent is one thing, and then evaluating it is a step that a lot of state and local governments haven't quite gotten to yet. Haven't quite gotten to. Whoa, those are chilling words. I want to turn to Teresa Miller, because Teresa is now with the Legal Aid Center, but she previously had important roles in state government, including as Director of Human Services in the Commonwealth of Pennsylvania. Imagine for us, Teresa, that you were tasked with spending that money. What kind of tensions do you think there would be for a government official faced with that choice?
Thanks for that question. I think, we look at money coming to governments as, oh, wow, what a great thing. You have all this money and now you can go spend it. But to your point, I think it's a lot harder than it sounds like, because you have so many different interests. You're going to have people and entities who haven't had funding, and those that have funding, all trying to get a piece of that pie. And from the Legal Action Center's perspective, we have advocated, along with a number of other organizations, for these dollars to go to evidence-based practices and really going to approaches that save lives, that help connect people to care, and that make communities healthier.
And so let's just drill down on evidence-based. Sounds really good. In terms of these dollars, what would you, as putting on your old hat at the Department of Human Services, define as evidence-based?
Well, I would define it just like Dr. McClellan. I mean, looking at the evidence, what does the evidence show? Does it show that putting money into X or Y place, does that produce better outcomes or not? And, we've had a 50-plus year drug war where we've arrested people and put them in jail. We know that's not helping. We know that's not evidence-based. And Dr. McClellan's presentation did a beautiful job of talking about how we know this is a chronic health condition. So locking people up is not, as we've seen, is not an effective way of addressing that. Getting people connected to evidence-based proven care that saves lives, that gets people connected to the services and supports that they need, making communities healthier, that's where we should be spending these dollars. If I were still in state government or local government, one of the things that we've advocated for and that I would hope I would do is look to the communities that have been most impacted and look to the community-based organizations, those people who've been on the ground doing the hard work of making sure people are getting the services they need, and find the gaps in the continuum of care that Dr. McClellan talked about. Find those gaps, because there are entities within the current system that have existing funding mechanisms, and there are those that don't. And I would argue a lot of community-based organizations are in that category. They do a lot of amazing work with very little money. And I think the opioid settlement funds are a great opportunity to get funding to those entities that are really on the ground.
But it sounds like they might not be treatment programs. So are they just doing good stuff and we should fund them because we got money?
Treatment is one piece of the continuum of care, but we've advocated for things like wraparound supports, housing services, harm reduction. I know Dr. McClellan just talked about views about overdose prevention centers, but there's other harm reduction like naloxone, syringe services, things like that we know are saving lives. And I think overdose prevention centers also do that. But it's really, from our perspective, about finding out from the communities that we're serving what they need, where are the gaps, and how do we help fill it with this newfound money.
Since you were in Pennsylvania, is there a community that comes to mind when you're talking about this, a specific place that you once served, once visited, that you could describe in terms of the impact of the opioid wave and how the organizations there deal with it?
You know, I think Philadelphia comes to mind, and you know, this is where it's hard not to bring up race and the impact that race has had in this country, and certainly the role it has played in the war on drugs. But when you look at Philadelphia, that is a place that has been very hard hit, and I think they're getting very creative about how to address these issues. Also, you know, the thing about harm reduction that I think is really important is harm reduction was created for and by people with lived experience. And it's sort of a ground up approach, making sure that it's addressing the needs of the community. And I think that's really important. And I think they're doing some good work in Philadelphia.
I'm going to move on to Irma in a minute, but Tom, I want to ask, are you okay with what you just said?
There are a range of things that are labeled harm reduction. I'm okay with almost everything she said. There are things that I don't think of as true harm reduction that I wouldn't spend my money on, like these safe injection sites. I just don't think there's evidence for them. But I don't want to, you know, cast too broad a brush here. I think, like everything else, follow the evidence. If it does what it's supposed to do and you can measure it, spend money and go that way. We spent a lot of money for a lot of years on ideology, things that people have in their minds that ought to work. Well, they often don't. But you can know what does work, and you ought to put your money where that evidence is, says I.
If you're on the District of Columbia City Council, for instance, as Irma, as far as the digs, was helping the council make decisions. National League of Cities. So Philadelphia is, I'm sure, part of the National League of Cities. What are you hearing from your members about this? Are most of them aware that this money is even coming?
Short answer, yes. And what we're hearing is that it's personal.
That it's what?
It's personal.
Personal.
In the sense that they know the families whose children are overdosing in their public school bathrooms. They themselves have been impacted by it. And so to the point that was made, you're spot on. It's having solutions that are really from the ground up. What's working? And let me just say, municipal governments don't manage their public health systems, right? That's at the county and the state levels. But because of what we saw, and we released our first report with the National League of Cities and the National Association of Counties, and pulled together, convened a task force that worked for that full year because this was putting a strain on their local fire, emergency personnel, and police in a way that was not sustainable. And community residents were looking to them to solve the problem. So they had to be the ones to roll up their sleeves and convene those advocacy organizations, those public health nonprofits at the community level to not just assess the scope of the problem, but to figure out what is there to help support. And to the question that was asked about what's working and what's not, it's some things as simple as just basic community education campaigns and awareness campaigns, especially if you see a particular population dealing with this more so than others, and having local officials, whether they be a very small community with a population of 1,000 or a very large community like the city of Philadelphia, being the ones to bring together and convene the different stakeholders that have a vested interest in this. And by stakeholders, those people that have either the solutions or the resources to be able to create a concerted plan to address this in a targeted and meaningful way.
So if I'm the mayor of Mechanicsburg, Pennsylvania, where Tom McClellan once lived, or any smaller municipality, I'm very tempted to use this money to pay for those firefighters that were overstretched, to pay for police, because I'm going to tell myself, well, if it's against the law and the police are out there disrupting the guys on the corner, I might prevent the start of substance abuse. Are those guys wrong?
No, and it's just as much about prevention as it is helping people get off of this and not become addicted. Just recently, National League of Cities posted a dashboard that delineated how much money municipal governments specifically have coming to them over the next 18 years. And in addition—
18 years.
Correct. So that they can plan accordingly.
How much money are they getting? Give us the shorthand.
I don't have the short answer off the
sorry.
top of my head, but I say that to say included with that is what are the things that other communities have done from a prevention, from a response, but then also how do you support the ongoing addiction that has happened? What are those ways in which communities, regardless of size or capacity, have been able to address this? Just last year during our annual legislative conference, our Congressional City Conference, which happens in March of every year, we convened the State Attorney General for the state of Alabama. We convened our municipal league director from the state of Arkansas. And then from Ohio, we invited the president of the Opioid Settlement Fund to come and talk about what is working and how city leaders, given the fact that they don't control their public health systems, what is it that they can do and how can they be really intentional about using these limited funds to be able to really meet the specific needs of their communities. And what that conversation, when it unfolded into, is people are dying every day. People we know, our neighbors, and we can't afford to not maximize what is coming to cities, especially because when Congress appropriated emergency funding to first deal with this opioid epidemic, most of that money resided with the states and didn't move to local communities expeditiously. So now that we have this opportunity and money is coming, how can they adequately plan for that? And the National League of Cities is working with city leaders to clearly write that out and make that available through its education efforts.
So I want to turn to Dr. Sally Satel, who here in Washington is seeing patients. We're talking about this as kind of a faceless program, but it's not faceless for Sally. What have you heard? How do you compute what you've heard so far? I'm going to make that a very broad invitation.
Well, the first thing is—
Hold the mic closer.
the first thing is the tensions over, frankly, what to fund. And what I mean by— I realize most locales are probably taking a pretty scattershot, and I mean that in a positive way. They're trying to approach, take a lot of systems, harm reduction, needle exchange, Narcan, better treatment, but one question is, do you approach this from the standpoint of what's going to help people who are addicted in a way tomorrow, or what could prevent a new population, or at least try to reduce that? And we're talking about younger kids, obviously. Or should the money go in addition, not only helping the people who have the drug problem or preventing others from having one, to the damage that addiction has done? And there was an article in the Philadelphia Inquirer last week, and Kensington, which is, as you know, probably one of the worst communities that's beset with encampments and a lot of open air markets and a lot of lot of overdoses. And they spent, Philadelphia received $20 million in settlement funds in 2023. Over a third of that was set aside specifically for Kensington and divided into 5 areas: one for parks, then schools, home repairs, rent relief, and support for small businesses. And there was outcry from some of the nonprofits that thought that that's not helping people who are addicted. But I personally think that's a good idea because
Well, wait a minute, that sounds counterintuitive. Explain your position.
why is that? How is that counterintuitive?
Because you're not helping directly serving the people who
No,
are
but
addicted.
I'm saying I think that we have to. I think that that's a legitimate scope to also pay attention to the communities that have been hurt. But more specific, I suppose. I don't have to go that far out into social reform or social repairs. Is just another a group. I don't know what its name is. It's a coalition of 192 national agencies. Oh, I think it's called National Sea Change Coalition. Does that ring a bell with anyone?
I know what you're referring to. It's a group of, it doesn't have a single name. It's a coalition of a lot of different
Okay.
community-based orgs.
Yeah, that's right. And they reject the idea of any of this money going for law enforcement. And that very much affects people who are addicted because they get arrested and they go to drug court. Hopefully, they can go to drug courts. I mean, unless someone's committed a significant crime, I don't think anybody thinks people who have drug problems should be in cells. But they should be under supervision. They should be monitored. And this is a therapeutic in a therapeutic context where then they're put into treatment and there's some leverage that they can stay there. Because one thing that Tom, if you mentioned it, I apologize, but didn't spend too much time on, and it was a great overview, is that your initial question was, why isn't it fulfilling its, and one answer is no one's staying long enough. The dropout rates are significant. If you're lucky, if half of the people in a program, more like 25%, stay an entire year. Some of that's because, the quality of treatment isn't so good. Some of that is because, frankly, there's no leverage and people are very ambivalent about giving up their addictions. As much trouble as it causes them, they also use drugs for reasons. I mean, it is a dynamic of self-medication, in my view. So anyway, I think that's, for what it's worth, I think that's wrong. I disagree with that coalition. I think that a good use of money would be in drug court and also re-entry. That's very important when people leave prison or jail. How do they integrate back into the society, their neighborhoods, which are the places they got very high in before they were arrested, and so they don't overdose. And we know that the rate of overdose, I saw one study that said 100%, but in any case, it's large, that you're at very high risk when you come out of a program and then go back into your neighborhood. And so methadone and buprenorphine are now being, and sometimes naltrexone, are being started in prisons. That's all good, and that's all within the criminal justice system. And so I would disagree with those 192 groups on that.
Sally, you spent some time in Southern Ohio in your psychiatric practice dealing with the opioid belt, we could call it. It was a very high-impacted area. Is part of your feeling about monies going for the communities rather than direct services to addicts informed by your own experience there?
Well, the communities are also part of why people, to some extent, why some people are mired in addiction, because they feel that their communities are completely devastated. So that does contribute. But I'd say there's a lot of universality to this problem, and where it's true in DC and it's true in this little town called Ironton, there's not enough long-term treatment. Even though I just said people drop out, you have to remember that every minute someone spends in a treatment program, they're not in an emergency room, or they're much less likely to show up with an OD in an emergency room, to commit crime, to show up for the job that maybe is under the table, but at least they're making some money and they're busy and they're productive. So even when, outcomes, if you measure outcomes, that we all want to measure them this way, you finish the program and you're not using drugs anymore, and that does happen for some people. But even when it doesn't, it's always a benefit.
So, Aniri, does this tension between uses of the money, first of all, I have to say in reaction to that is, this could be really good news, billions of dollars, could be really good news. So we don't want to forget that as we talk about what mistakes can we make and all of this. If all these people are not in treatment who could be directed to treatment, this could be really good news and a really big deal. So let's not lose sight of that. But Aniri, does the tension that Sally just described from that Philadelphia Inquirer article about where to use the money, is that echoed in the reporting that you have done at the local level?
Absolutely. I think lots of different tensions have come up in just this group of 5 folks here. And if you look at the money being used in thousands of cities, counties, states across the country, there are lots of those tensions, right? Law enforcement or not, treatment, but what kind of treatment? Primary prevention aimed at kids, but is it just say no, or is it mental health resources? I'm a small local government and I have a budget that I have to balance, and the ARPA dollars are gone and now I have a hole and this opioid settlement money is coming. Can I use that? Can I use it to pay for the salary of my health director, and the money that I normally use for their salary, can I use that to fill up potholes? While other people are saying, hey, the opioid settlement money is here to add new services and expand what we're doing, because what we've been paying for so far is not enough and we need to do more. So I think the tensions, I could spend a whole panel talking to you all about the tensions that are true and popping up all over the country around how people want this money spent.
So these are debates on city council floors?
Absolutely. City councils, county commissioner meetings. I've watched a lot of those where people have very differing views about the money, where advocates come, where the sheriff's office comes, folks are asking for the money or talking about it. And sometimes the debate doesn't happen until after the decision is made, because people may not know to show up to that meeting. The decision is made, it shows up somewhere, and then people say, hey, that's not what I wanted that money used for.
A lot of people compare this to the tobacco settlement monies, which I mentioned in the introductory remarks, and that's the same tension played out. Tom, you're leaning in.
I just wanted to point out something. Sally brought it up, but for 50 years, there's been this terrible, wrong tension between law enforcement and treatment. It's like it's one or the other. Any good person in treatment knows that it's almost impossible to prevent relapse in a community that is overflowing with drug availability. So we need law enforcement to reduce drug availability. From a factual point of view, drug courts, Sally mentioned, others have mentioned.
Tell us what a drug court is for the uninitiated.
A drug court is where a person is charged, is arrested for a drug-related offense, let's say robbery in the service of supporting a habit. And he's offered a choice, very importantly. You can either go and get sentenced, or you could go to this drug court. Now, the drug court will force you to go to treatment, and they will force you to show up every week to show whether treatment is working. You'll have to submit urines, all that. If you pass the drug court, and it's usually 6 months to a year, your charge is expunged. You don't have the charge on it. If you fail, you've already said you're guilty, so you're going to go to jail. So it's the combination of treatment under conditions where there's, let us say, artificial motivation. And let's go back to the brain stuff. These are brains that are not completely functioning. So I can't tell you how many people I've evaluated 6 months after care saying, thank God my parole officer forced me into treatment. I wouldn't have gone. So it's just an unfortunate tension that doesn't have to be.
So Teresa, the Legal Aid Center is obviously looking at the legal arm of this. Do you agree with Tom that forced treatment is necessary in some cases?
You know, the Legal Action Center sort of leans away from forced treatment. I think from our perspective, we've tried kind of the law enforcement approach now for a very long time, and we've tried having law enforcement be those first responders. And going to prison or going to jail when you have a chronic health condition just doesn't lead to the best outcomes. And so I think from our perspective, and I would encourage any local governments who are thinking about how to spend these dollars to think about crisis response. And from a legal perspective, there's...
What does that mean?
So crisis response, when someone's in a mental health or a substance use disorder crisis, who's responding? So when you call 911, for example, if you call 911 and you're having a heart attack, the police don't show up at your door, right? So you have trained paramedics that show up at your door. But if you call 911 because you're having a mental health crisis or an SUD crisis, oftentimes in most cities, you have law enforcement that are responding. Law enforcement that I think oftentimes agree they are not best prepared to respond to those types of calls. So there's a lot of discussion now with the new 988 suicide hotline and crisis hotline. There's a lot of discussion about how can municipalities do a better job of changing the way they respond to these crises. So instead of sending a law enforcement officer with a gun to a mental health crisis, how do we have someone who's trained in dealing with mental health crises?
So I assume those could be new hires with the opioid settlement monies?
Exactly. And back to the point I made earlier about looking for those gaps in that continuum of care, there's a lot of discussion around crisis response about who do you call, who responds, and then where do people go? Thinking about the gaps there and how do you get people who are more appropriate than law enforcement to respond.
Who would those people be exactly?
There's, you know, municipalities around the country are doing things like having peers specialists, having mental health counselors be the people who respond to these crises.
Are these psychiatrists, psychologists?
Not always, sometimes social workers, not always psychiatrists, and they don't have to be sort of, you know, PhDs, and peer specialists are often a part of it. So oftentimes there are teams of people who are just much better prepared to respond to these types of crises. Rarely in these calls do you need a law enforcement officer. So from our perspective, again, because jail is just not going to be the best place to treat a health condition, if we think about crisis response differently, that's a way to avoid the whole jail and carceral system and get people connected to the care they need, not just treatment, but maybe other social services and other care that they need.
And very large percentages of our prison population do have drug and mental health problems.
That's correct.
Tom, I know you have an idea, because I want to keep this focus on what should local and state governments do, and we're hearing an idea there from Teresa, hire more first responders of a different sort, very specific. We've heard about community repair, I'll call it, that Sally was talking about. You had some ideas about how to contract in the political context, and you referred to this in Delaware. If you revoke contracts, there's going to be an outcry, right? So if you think that there's a bunch of Irma's cities that are actually spending their money ineffectively, if you say, we're going to defund these treatment facilities, one can expect a backlash.
They'll never get
how would
elected.
you advise her cities to deal with that potential?
Well, I'll say a few words about that, but I thought it was a very important point that was made about small communities don't control their healthcare system. That's very important. One of the things small communities can do and do better than large communities is prevention. And this is not my opinion, this is a fact. There are now studies done, large-scale studies in prevention that say you don't need drug abuse prevention, early pregnancy prevention, high school dropout prevention, mental health prevention. You need healthy living prevention, and it's best done at the community level with
Healthy living promotion.
Yes,
We don't want to prevent healthy living.
No, yeah, good point.
Just checking.
Good point. Good point. But it's best done, works best, and the results are very impressive. Like 40% reductions in early high school dropout, drug use, criminality, everything. And that's the kind of thing that a small community can do amongst its...
Well, put some meat on the bones for that. What form would that actually take?
Point one is it's generic prevention, healthcare promotion. It's not very specific stuff. That doesn't work. It doesn't work because all the things that are killing and harming our young have the same generic antecedents. Two, it works if, like treatment itself, it works if it's chronic, not you get a course in health in your 8th grade saying drugs are bad. Okay, we've just had prevention. That don't work good, okay? But chronic prevention does, and it's best when it's age appropriate and it comes from the entire community. The police have a role, the schools have a role, the clergy has a role, the parents learn new skills. And again, I'm not talking about fictitious ideas. This has been tried and very successful in Washington, Iowa, and Pennsylvania, as a matter of fact. So that's one thing that small communities can do. Again, back to contracting, turning again to treatment, every insurance company now wants to see the full continuum of care. Most states want to assure the public that they're getting the full continuum of care.
And why are the insurance companies interested?
It's part of the Affordable Care Act, is they have to have that continuum, meaning detoxification, residential care, intensive outpatient, outpatient. And the way most states do that is they make separate contracts. They get residential care from Our Lady of Perpetual Misery. They get detoxification from this place. Shady Acres does that. Everybody's got a contract. But those programs are not connected. You can't go from one to the other. You have to be discharged and then admitted. It's not at all like being in a hospital, but it doesn't have to be that. In short, it's like me saying, I have a car. I've got the tires and wheels down there in my basement. The engine's up in my spare bedroom. I got the body in the backyard. I got a car, but it doesn't run. And the way some states are curing this is they're saying to these treatment programs, if you can get yourselves together, some are forming nonprofit corporations that allow them to specifically transfer, then the state buys something that has real value, the true continuum of care, not just the pieces.
You also have a thought about different types of licenses.
Yeah, that's
in order
another,
to deal with the fact that there's an incumbent advantage.
Absolutely.
People already have contracts. Tell about that.
State of Arkansas, good example. They know very well you can't, even if you know for sure that Shady Acres is doing bad care, they can't get rid of that program. It's just politically impossible. But they can give different levels of licensing. A program that says, I proudly want to do group therapy and only group therapy could get a level 1 license. They can continue their practice and they can do, as was said earlier, they can do recovery support, continuing care. But you could, if you joined with a hospital and had a physician and you had an electronic health record and could provide all the kinds of care that you really need to address, you could get a level 2 license, which gives you a lot more money because it's worth more money, because you're getting the full set of things that you need to address the illness. I mean, imagine a diabetes program says, we don't use no stinking medications. No, sir, we just do diet. Well, suppose they got a license to do that, but they didn't offer any of the medications or any of the other services. It'd be preposterous. It'd be, malpractice. Well, it's done all the time in addiction because of its historic, it just grew up that way. Sorry, I went on too long.
Was that your experience in Pennsylvania, Teresa, that these programs were, to use the bureaucratic jargon, siloed and they didn't relate to each other?
You know, I didn't necessarily have a lot of experience on the provider side. So at DHS, we contracted with the managed care organizations. And I think the one thing that was resonating with me from this discussion was it's very hard, purposely very hard, to end certain contracts. For us, it was contracts with managed care organizations and just start new ones. So in Pennsylvania, while I was there, it was taking years for us to do a reprocurement. And again, some of that's by design. They don't want people to be able to just come in and make those changes overnight, but it means that change is hard,
Yeah, so there's an incumbent advantage.
for sure.
So here's a kind of an out of left field question. We've seen new figures come out that the overdose death rate has declined. So I want to ask you, Sally, or anybody else who wants to weigh in, and everybody should feel in to jump in at any time. Don't feel I have to invite you. Is it possible that, as with crack cocaine, this opioid epidemic is going to peak and ebb somehow on its own?
Yes, that is possible. That's possible. I don't think we, know that yet, but it is encouraging drop. 15% nationally, like 28% in Ohio. I think North Carolina is even more. So that's definitely encouraging. There is a lot of speculation about why, from having Narcan, and it happened fast. So that's what's really interesting, and also kind of worrying. It almost seems like it's, if we don't know if we can't tell what happened that made it happen so quickly. So again, maybe it was a pretty robust ramping up of Narcan, the
Overdose prevention?
overdose things, yeah, overdose prevention. No, it's not prevention. The overdose reversal medication.
Right.
Yeah. Maybe more people did get into treatment, although I don't think they did. Actually, I think that was stable. Although I should also add, there's a lot of local differences whenever you talk about this issue. But I just read something the other day about maybe there's a little less Sinaloa cartel got interrupted. Perhaps there was fewer, less drug coming in. People are using, not intentionally at all, but there's a drug called xylazine, which finds its way into the supply, and it causes these, horrific necrotic sores on people's bodies. So that may be not only an aversive development, something that really scares people, and either sends them into treatment or sends them to methamphetamine, but also that xylazine is very sedating, and it's like so many of these, it's a veterinary drug, and basically people sleep through most of the day, whereas they might have essentially, had the xylazine not been mixed in with their heroin and fentanyl, they would have been awake for those 8 to 10 hours and injecting more during that time period. So there's some speculation that there's literally less opportunity to overdose because you're just using less, because xylazine is keeping you essentially.
So put it in another way.
There's more, but those are some of the
fact
big.
that overdoses.
And then the burnout, as you say, younger generations see what's happening to their older siblings and their parents. And this you alluded to crack. I mean, that's a kind of situation where, there's a real burnout that's just intrinsic to a repulsion at seeing what's happening to the people around you. But I'm sorry, go ahead.
Well, what I get from you is that the fact that overdoses may have declined or have declined doesn't mean that addicted behavior has declined.
No, in fact, this is an overdose epidemic, even more than it is an addiction epidemic. I mean, I don't know that we're seeing many fewer addicted people. We're seeing fewer people who have died. So that's important. And I'll just throw in a final complication, is that carfentanil, which is about 100 times, it's 100 times as potent as fentanyl. So, and fentanyl is about 100 times as potent as morphine.
It says a nuclear bomb is to TNT.
Yeah, it's bad. It's used for elephants, literally. So, another veterinary drug. So, if that gains momentum, well, that'll be disastrous. Also, there's a new form of synthetic opioid called nitazines, and they are more potent than fentanyl. So there's a reason to be very caustically optimistic.
So all the more reason to get people into treatment that works, so they don't use these new drugs. Irma, we've talked about local. I know you're a director of federal advocacy for the National League of Cities. Is there a federal role here that you think is important to appreciate?
Absolutely, especially, just to the point about how has it changed or evolved? I've been with National League of Cities now 8 years, and at first it was about opioids. More and more leaders in the last few years have beyond two. It's about fentanyl. And our public health professionals that do this work every day at National League of Cities tell me, Irma, you really need to frame this as substance abuse. I think, so yes, there is a federal role for this because of the coordination, and frankly, the dynamics are different in every state, which impact the localities and what they have to do. And there has to be a connection between what happens at the local, state, and federal level, because the reality is Congress, each administration is gonna have very tough decisions to make as it relates to budgeting and appropriations. And so where are those programs that make the most significant impact? Especially when you take into account the fact that we have a mental health crisis, isolation crisis in this country, and what does that really mean for limited public health resources?
Neri,
Can
you're
I-
leaning in.
Yeah, I wanted to jump in there because you asked about the federal government role. I think it's a question I get asked a lot from readers of just the general public, like, hey, what's the federal government doing on this opioid settlement money? And by and large, the question is not, or the answer is not a lot. The settlement agreements are between companies and state governments for the most part, and so the federal government is not a party to most of the lawsuits. That doesn't mean they cannot play a role in it. They could, there was a bill introduced in Congress to legislate how this money could be used at the state level. There was, several Congress lawmakers in Congress who wrote to the Office of National Drug Control Policy and said, hey, can you take a more active role in overseeing, maybe creating a centralized database, places where this money could be tracked or best practices could be elevated. That, by and large, hasn't happened. So I don't think we've seen a lot of active government role on this. You do see, when you're talking about the broader landscape of addiction treatment, law enforcement response, all of that, of course, the federal government is in. The Medicaid is the largest payer for addiction treatment in our country. But I haven't seen them weigh in really on the specifics of the opioid settlement money.
So you would agree with what the phrase Tom McClellan used, that the government can be a market maker here, but in terms of what it reimburses via Medicare, Medicaid?
I think a lot of folks that I've spoken to who've had current or former roles in government say there are a lot of things that the federal government could do to steer state and local governments around how to use or not to use this money. They have different levers they could pull, essentially. Okay,
I'm going to turn to the audience and the online audience for questions. And it's, if you're online, it's hadar, HADAR.zeevi@aei.org. Open to you all. Anybody here in person have a question or a comment or a complaint? Do we have anything online? Nothing online. Anybody else want to make? Everybody gets a final comment then.
I'll start. I think what is most important about the opportunity with the settlement funds is for communities as a whole to have the flexibility to not just rapidly respond, but based on what's happening, really tailor the responses, the supports, the solutions to what are the specific needs and circumstances on the ground. You all mentioned the decisions local leaders have to make. Mayors and council members have to make tough decisions about what they prioritize every day. And it is not easy. As you can imagine, everybody has their own ideas or best practices on how those limited dollars should be spent. But the reality is there is a housing crisis where they're racing to build their infrastructure. There's a mental health crisis. There's a substance abuse crisis. Like, there are just so many competing priorities, and you can't address one solution at the expense of another, or one issue at the expense of another. So it's about coming together for those people that do this work each and every day, being the ones to advise and to support and not just throw stones, because we're not going to be able to meet the needs of each respective community as we do it, because otherwise people are going to continue to die.
Aniri, remind us of the website with that great new report that you issued today.
Absolutely. So you can find it at kffhealthnews.org. That's KFF Health, like healthcare, news.org. But I want to say in closing, kind of, my perspective as a reporter, I've been covering addiction and mental health issues for many years, generally writing about a lot of the problems and the harms that we've been talking about. So when this money is coming in, the opioid settlement funds, right, totaling about $50 billion spread out over 18 years, it's an opportunity. And a lot of people I talk to see it as an opportunity to build treatment infrastructure, build recovery services, invest in childhood prevention. It's also an opportunity that can go wrong, the way a lot of people tend to look at the tobacco settlement money of the 90s. And so I think all the tensions you see highlighted here are playing out, and they're playing out because a lot of people care very strongly about how this money is used, and they want to be able to know how it's being used and track that and then evaluate it and see, 5 years from now, do we need to change strategy and do something different for the final 10 years or for the final 15, whatever it is. So as a reporter, a lot of my job is just trying to figure out where the money is going. There's not always a lot of transparency around that, and hopefully making that information more public and spurring more conversations around it. So folks are interested in some of the information we've put together so far, you can check that out at kffhealthnews.org.
So at the risk of being cynical, we know you're going to have a story to cover for quite a long time.
Yes, this has already been a 2-year series, and I'm sure there will be many more years of stories to come.
Sally, final thoughts?
Yeah, just to reiterating how important it is that people stay in a treatment program, and that's because this is one of the most enduring facts of drug treatment is that the longer you stay, the better you do. You just internalize the values we used the word abstinence. I realized the first time I said that to Doug Besheroff, he was so confused because he thought it was sexual abstinence. And also the importance, all the, what therapy does, which a lot of it is really try to cultivate a habit of self observation, so people understand what situations make them vulnerable, and of course they have to start working, and then working can pose its own challenges, and then it's helpful to talk about that with the counselor. How do I negotiate
Sounds
these
like that's
problems?
what you do every day.
Well, I do the methadone, but that's really what keeps them there, at least at the beginning. And so it's important for people to stay, and that is my segue into another point that Tom made, which is this almost false dichotomy between criminal justice or corrections and treatment program. And if I have a patient who is leveraged to be there under a system of benign paternalism. In other words, you really have to go or there'll be a different consequence. God, that is so helpful. And one thing you said, Teresa, I guess I disagree with you a little bit on this, is that, of course we don't want folks in cells, but, if you commit a crime, there has got to be accountability for that. So better a drug treatment program than the kind of consequence that would befall someone if they weren't addicted and committed that same crime, because that is a jail cell.
Teresa?
I want to go back to a point that was made just a little bit ago around what we're seeing now in terms of the reduction in overdose deaths, which of course everyone's celebrating. That's wonderful. But I think it's important to note that we're not seeing that across all demographics.
Definitely not.
So deaths for white people are definitely going down.
Which were previously disproportionately high, so we've seen a reversal there.
And now, if you're looking at the Black population, Native American population, we're not seeing that same decline. So I just wanted to point that out. And I guess the other thing I would just urge, since this is a forum for local governments and others who are trying to figure out how to spend these dollars, is I think in this country we have a history of sort of deciding for communities what's going to work for them. And I would just encourage folks to really get on the ground and listen to the people that you're serving and figure out from their perspective. That means including people with lived experience in the dialogue and in the discussion and the development of solutions, people who are actively using, not just necessarily people who've been in long-term recovery. You need multiple perspectives to make sure that the solutions that you're coming up with are really going to meet the needs and really turn the tide and make sure that people are able to get the care that they need when they need it.
Thanks so much. I would just say they might want to call this guy, but and ask Tom McClellan, because he seems to be deeply informed of this. But last comments, Tom.
Well, I would just say that, look, there's tremendous value at the individual, family, community, national level in recovery. If you get more people in recovery, it is the real value of addiction. As a guy who spent his life in addiction, working in addiction treatment, that's not the point. Treatment is the way to the real value, which is recovery. And number one, there are more people today in stable recovery than are addicted. Most people don't know that because they look just like every other citizen. And they're anonymous. But don't forget that. This is an illness that you can recover from. Two, these new dollars offer opportunities that you don't have. Yeah, they're competing demands. Yeah, it's tough to make decisions. But it's crazy to keep doing things in the good old-fashioned way when that's not the thing that's providing value to the state or the country. So I really encourage a time to put evidence into play, try things that might work, use the power that states have and communities have for the very, very good things that they can do.
Please join me in thanking our panel.